Good afternoon, everyone, and thank you for joining us this afternoon to talk about telemedicine. As many of you have experienced during the COVID pandemic, several of us doctors and new patients and families have been connecting with your doctors with telemedicine and virtually via telehealth. And even if for some of you this has been a new experience, some of us have been doing this for a little while now. And today I wanted to share a little bit of my experience at Mass General Hospital, where I practice and where I have been doing telemedicine for a while now. So I would like to share my screen to tell you a little bit more about what we have been doing. So as I said, I do practice at Mass General Hospital, which is located in Boston. And since 2013, we have been piloting virtual visits and telemedicine in the hospital. I myself started doing this back in 2014, and we started at a much smaller scale back then just because we didn't have any reimbursement from insurance, and the hospital wanted to see whether how efficient these telemedicine visits were compared to a face-to-face visit in the hospital. So we had 4 modalities that we had available for us to use. Some of them are called real-time modalities or synchronous visits. These are visits that we called either virtual visit when they entailed a communication between a patient or a family of a patient with the doctor directly, face-to-face, or a virtual consult between 2 medical professionals to discuss the case of a patient. We also have asynchronous or store and forward virtual visits. These are requests for consultation that are submitted to the physician that can be answered asynchronously. So we don't have to be face-to-face in contact with a medical professional or the person submitting the request for a consultation or a second opinion, and we can respond by email or by writing down a full evaluation electronically. So what I'm going to be focusing on today are really the real-time virtual visit face-to-face with the patients and their family. When we first started this, we had surveyed doctors and patients that have been doing virtual visits for as a pilot. And initially we surveyed 60 physicians, and we asked them whether they would recommend virtual visits or not to their colleagues. And we saw that several of them definitely would recommend them, and many of them will probably recommend these visits to their colleagues. So the majority of the physicians who did these virtual visits felt comfortable enough and felt that they were helpful enough to recommend them to other doctors. A lot of the physicians who did the pilot study went through a training to show them how to use the special software that we use for these virtual visits, and they found these training sessions very helpful, as illustrated here by this purple section of the pie chart. Before feeling comfortable doing these virtual visits, physicians who had never used them felt that 1 or 2 visits were enough to make them feel comfortable using these visits with their patients and their family. This shows you how easy these were to conduct. So there wasn't too much technical involvement in them, and anyone can actually become very efficient in doing them. As to whether these virtual visits were equivalent or comparable to the face-to-face visit, we were happy to see that for most doctors that have tried them, they felt that virtual visits were either better, which is the turquoise color here, or had no difference with a face-to-face physical visit, which is the yellow here. So for the most patients, doctors who have done these with their patient felt that virtual visits were a comparable method to seeing their patients. We also asked the patient what they felt about doing these virtual visits, and we had 129 responses initially. And we were also happy to see that the patient shared the ease of use and the satisfaction of doing these virtual visits with their doctors, where the majority of the patients have felt that virtual visits were better or no different than physical visits face-to-face. Few have said that these visits were less efficient than office visit, and that primarily pertained to the personal connection they felt with their clinician during these visits, or the interruptions during these visits. But for the most, there was a lot of confidence in having these visits being conducted by a healthcare professional. They felt mostly a good personal connection with their clinician, and they felt comfortable sharing personal information and private information electronically. So this was very reassuring, and the pilot phase extended. And since 2014, we have done several of these visits. As I said, we initially started slow, but we ramped up over the years. And the data that I'm going to show you really pertains to only a period of about 20 months from September 2016 to January 2019. This does not include the data from the pandemic as of yet. So we had 81 visits done virtually, done primarily for mitochondrial disorder patients that were genetically confirmed, but also for suspected patients that were in the process of being worked up. The demographic information of the patients that were seen in our clinic were as follow. The ages, the average age was 39.7 years, and we saw both pediatric and adults with ages 9 to 72. We saw more females than males, and that has been my experience for every study that I did. We always have a lot more females participating than males, something that we need to improve. And the length of visit in general was about 23 minutes, with a maximum length of 51 minutes, and the shortest one was 7.5 minutes. So you see there is a lot of variability depending on the topic that was discussed. In terms of the geographical coverage of the patients that were served by these virtual visits at Mass General, we primarily saw patients within the Boston area and the larger metropolitan Boston area, but broadly patients from the whole New England as well as from the larger US continent. So we have been able to see patients from far away and from near the hospital, and technologically it hadn't really made any difference. We were able to see them and hear them properly. The visits that were done via virtual visits were primarily for patients who have been at home. And when I initially started doing this, I was thinking that this would be really an option that would benefit patients who have limited mobility. So those, for example, who are wheelchair bound or had difficulty with ambulation and travel, but only 7 out of these 81 patients really had any mobility issues. And so mobility isn't the major reason of why patients elect to do these virtual visits. And I failed to say that we had given our patients the option when they called in to schedule an appointment as to whether they wanted that appointment to be a virtual appointment or an in-person appointment. So this was really a patient's choice as to whether they wanted to do this or not. So most of our patients, 94%, were having these visits from home. Some patients elected to do this from their place of work because they couldn't take time off, or I even had a patient talk to me at the airport before boarding a plane because that was the only time that we were able to find to talk. For the most, patients presented alone, so they were in front of their computer or phone or iPad or tablet by themselves, but in 47.5% of the cases, they were accompanied by a caregiver, whether a parent, a spouse, a sibling, or a child. We have seen it all the combination were present. The reason for the visit for those who have chosen to do a virtual instead of a face-to-face visit physically were primarily for genetic counseling. So those are the new patients that have been evaluated and had some pending genetic testing. So instead of traveling to the hospital to have that discussion face-to-face, they elected to do this virtually. 40% of these visits were to discuss test results that were non-genetic test results, so blood work, MRIs, radiological testing. 4% were just to check in, to say hi, how you're doing. If someone had come in already to talk about an acute problem, to following up to see how they were doing. 7% used these to discuss a specific symptom, whether it's new or worsening symptom. 24.7 was for their regular routine scheduled follow-up, and 7% were when we could not have physical clinic because of a thunderstorm or a blizzard, and we had to cancel physical clinic. This was a great option not to cancel clinic completely, but to switch everyone who was scheduled to come in person to a virtual visit. And we were lucky at Mass General to have a very robust telemedicine service that allowed us to switch everyone and make sure that they have the technical capabilities of doing virtual visits from home. What happened after we had virtual visit? Did we do similar intervention or a plan than when we had a face-to-face visit physically? The answer was yes. The post-visit intervention led to changes in management in 19% of the cases. So this is changing a medication, adding a medication, discontinuing a medication, ordering more tests in 41.5% of the cases, providing a new prescription or a medication change, doing referrals in 23% of the cases, and in 20% of these visits, no changes were made. So what we've learned from doing these virtual visits before the COVID era is that these were extremely helpful for our patients and for our doctors. And I will speak for myself, my patients specifically have saved thousands of miles of physical travel to come into the clinic. As I showed you, they were coming in from all over the US and New England. And so being able to do these virtual visits have limited the amount of traveling that had to be done. They also saved financially a lot of money. So on average, driving to Boston and parking at the hospital would cost the patient about $45.50 in travel costs, including gas and parking fees. Those were gained by not having to expense them, and ultimately decreased in the cost of the office visit itself. So for every face-to-face visit, the insurance has to pay for that visit, and the cost of those visits, depending on the complexity and the amount of time we spend with the patient, ranges from $68 to $234. In contrast, a virtual visit, it's either $0 out of pocket or $25 out of pocket at Mass General at least. And so there's a big discrepancy between the cost of these visits that were saved, whether the patient decided or elected to be seen physically or to do these virtual visits. So these were all very positive findings. In terms of the benefits that I saw for myself was that I was able to see more patients, because when during our clinic days we are limited by the physical clinics, meaning the physical space where we need to see patient, and you cannot schedule more patient that there are hours during that allotted time to see patients. So virtual visit allowed me to be able to see patient after hours, before hours, over the weekends, and add on patients, even if it wasn't a clinical day and I didn't have a physical space that was reserved for me to see patients. What I've learned and what Mass General has learned by having observed several doctors, such as myself, doing virtual visit over time and before the COVID era, is that telemedicine really had a promise to improve access for patients in general, but more specifically for patients with mitochondrial disease, and allow them to have more expert access to mitochondrial care at Mass General Hospital, because most of these patients lived in areas where there wasn't an expert close by in the local hospitals. Before the COVID era, we're also in the process of expanding the use of telemedicine and in the process of more systematically studying the clinical outcomes for these clinical virtual visits, meaning to compare whether doing these visits virtually would lead to a different clinical outcome than when we see patients physically face-to-face. We remain mindful, however, that there are still many challenges pertaining to telemedicine in terms of the clinical limitation, not being able to examine the patient right there, not being able to do rapid follow-up testing when the patient is there. You can draw the blood, you can send them to radiology if it's an acute issue to get their MRI or any other testing readily. There are also some social and legal barriers in terms of if I'm doing clinics in Massachusetts, I'm usually licensed only in Massachusetts, and so are several of my colleagues. So we are not able to see, or at least we were not able to see patients from other states for the first time as a new patient, and we had to see those patients physically first. And then when they became established patients to us, we were able to follow them virtually, but not the other way around. So that remains a huge barrier for us, which still remains a major problem that you will later hear about from Dr. Cohen and Dr. Parikh. The reimbursement issue is also a problem, and we will hear more about how COVID may change that. The fact that I was able to do all of this because this was a pilot study funded by our Massachusetts General Hospital Physician Organization meant that I was getting reimbursed for my time seeing these patients by my organization. And most of the insurance companies didn't fund or didn't reimburse for these visits. And that's the reason why we did this pilot study. Is Mass General gathered so much information and presented these to some of the payers who over time, after a 5-year worth of data that we gathered, have started paying for these visits. So I'm happy. I was lucky to be in Massachusetts to be able to do some of these visits and have them be reimbursed, but this remains an issue in other states. What we want to do throughout this session today is to tell you how things have evolved over these past month with COVID, and how we are morphing into having more people doing more virtual visit, and how that changed the landscape of telemedicine in the US, and what do we envision for the future, and also how are we expanding these efforts into the mitochondrial care network. And with that, I would like to thank my team, Dr. Walker, who also was seeing patient and whose data was incorporated in these slides, Michelle and Erica, my coordinators, and of course the MGH Telehealth department. And thank you very much.
What I would like to talk about is what the Health and Human Services 1135 waiver accomplished two things. The first thing it accomplished was it removed the barriers for a physician holding a medical license in any given state, removed the barrier for them to actually provide the medical care when the patient was in a different state. So I hold one medical license. I hold an Ohio license that allows me to practice medicine in Ohio. As soon as I reach over the border of a state to take care of a patient, whether it be in person or using a telemedicine service, I don't have that right to do that. So I don't have the right to use a telemedicine service to communicate and take care of a patient who physically is in the state of Pennsylvania at the time that we're talking. That would require a Pennsylvania state license. And so the first thing the waiver accomplished was it allowed the states to say, we're going to give every other state reciprocity to allow physicians to cross over state lines using telemedicine equipment to take care of patients residing in another state. And when you think about how long that would have taken if every state tried to run this through their legislature, it would have taken years and years and years. But in one fell swoop, Health and Human Services said, you can do this if you want to do it, and all 50 states agreed to cooperate. So that allows me to use my telemedicine services in any of the 50 states. This may actually end pretty soon when the public health emergency is over. It may revert back to the old days of February 2020, which would require me to hold state licenses or some sort of certificate in every state for which I want to practice telemedicine in. So last month I saw patients from 20 different states. If this barrier is put back in place, I'm going to have to contact 20 different state medical boards so I can continue to provide telemedicine services for my patients in those states. The second thing this waiver accomplished was it required Medicare to pay for telemedicine services at the same pay grade as they do for face-to-face services. Now, Medicare is the largest insurance company in the United States. Very few patients with mitochondrial disease actually have Medicare as their coverage because it's really for people older than 65. But when Medicare makes a decision to pay for something, most of the state Medicaids go along, and most of the commercial insurance companies like Blue Cross Blue Shield, Aetna, Cigna, United, they go along as well. So Medicare makes a decision. Within a few days, the other insurance companies generally make the same decision that Medicare makes. When you go to see a physician in their office, the insurance companies and you are paying for two things. And they're actually broken out into two different sub-bills within the same bill. You're paying for physician work, and that's the work the doctor does during the office visit or during the procedure. And you're paying for something called a practice expense, and that's how much it costs to deliver that service for rent on the building, the exam table, the wear and tear on the office, how many nurses it takes to get you in the room. That's all covered by what's called a practice expense. And you can imagine with telemedicine services, the physician work expenses are going to be about the same. If I spend 20 minutes with a patient face-to-face or 20 minutes doing telemedicine, it's pretty much the same bill. It doesn't cost me any more or less to deliver that care. Practice expense is a very different thing. When you think about what the practice expense is for telemedicine, it's this. It's the cost of my cell phone. I don't even have to leave the comfort of my house to deliver telemedicine services. If I go into work and see a patient face-to-face, I've got nurses I've got to pay. I've got rent I've got to pay. I've got heat I've got to pay. I've got the insurance on the property I've got to pay. It amounts to about 40% of the total medical bill. So what may happen when the public health emergency ends is the insurance companies may say, we're happy to continue paying for the physician work, but we're not going to pay you what we paid you for in terms of practice expense. So again, right now on a $100 medical bill, $60 goes towards the physician's expense, $40 goes to the practice expense, and the insurance companies may say, we'll pay you that $60 for this physician work, but we're only going to pay you $5 for the practice expense. That changes the calculus on how telemedicine services will be continue to be delivered in the future. I personally think that the toothpaste is out of the tube. We've gone to telemedicine. I don't think we're going back so quickly to all face-to-face services. So it ends up there's more than just one telemedicine service. And I'm going to talk to you about the four that exist and that are in use now. And two are in more use than the other two, but pretty soon we'll have all four up and running. And these services depend on four different elements. The first is whether the service is synchronous, meaning in real time, or asynchronous. This talk is being delivered on a computer on a Wednesday evening. You're listening to it probably on a Saturday, although you may be listening to it on another day because it's going to be posted to the web. That's asynchronous. It's not in real time. Synchronous means it's in real time. There's a banter back and forth in real time. So a telephone call, for example, is synchronous. You're talking to the physician's talking to you. It's a back and forth conversation. The second element is whether there's video or no video. That's self-explanatory. The third element is whether the service is delivered in one session, whether it's like an office visit, you got your 20 minutes, or is it delivered over the course of a week? And we'll talk about what services can be delivered over the course of a week. And finally, the specific technology being used, whether it's a telephone technology or computer technology. So these are the distinguishing features of what we call non-face-to-face evaluation and management services or telemedicine services. So here are the four different services. The one you've been using for years have been the telephone services, and this is defined as the patient calling, saying, I've got a question for the provider. And then either the provider picks up the phone or calls the patient back, and there's a conversation, there's a discussion, the physician makes decisions about what we can do. for the situation, discusses it with the patient, the decision's made, you hang up the phone. That's a telephone service. And again, those have been defined services for decades. They weren't paid for until this public health emergency was declared. The second service that really came into all of our living rooms in the last couple months is what we call synchronous with audio and video link, the blue bucket. And that's like an office visit gets set up. You pre-schedule for a visit on Thursday at 8:20. Usually what happens is you'll get a little beep from your cell phone saying it's time to link up. The physician has that same connection to you using audio and video real-time connection. It's like you're having a video conference with a family member. And generally the work that is done mimics what happens in the office visit, except for some features of some parts of the physical examination. Obviously, one can't take a blood pressure over audio-video link. One can't use a ophthalmoscope to look in the back of someone's eye. There's no stethoscope that I can use right now to listen to a heartbeat. And so those are the synchronous audio and video services that, again, are being paid for now at the same rate as a office visit's being paid for. The third orange bucket is the digital online evaluation and management. This is a great example of what happens in dermatology. A patient develops a mole or a rash. They take a picture of it. They send it digitally to the physician. And in an asynchronous fashion, not real time, the physician looks at it within, hopefully a day and gets back to the patient saying, this looks like poison ivy. I called in a prescription to your pharmacy. You can go pick it up. These services, this back and forth banter, can take place over the course of a week. And at the end of the week, the physician can submit a claim for payment. And that's called online digital evaluation and management. And the fourth is an interesting concept. It's called interprofessional consult. So the patient actually doesn't even have to show up for, and in fact, the patient doesn't show up for any of this. It's me calling another professional on the phone and asking for essentially an opinion about the patient's care. And the computer background work for this bucket has not been built out in most hospitals, but will be soon. But it allows us to take care of patients in a much less expensive fashion by using this type of consult codes. So those are the four buckets of telemedicine that exist in the United States, with the blue bucket being the one that has really taken the world by storm. I can't predict what the payment model is going to be a month from now, 2 months from now, 3 months from now, but I do think that telemedicine is here to stay. So what patients fit into telemedicine services, which patients don't? And we're working through this with our patients week by week, month by month. So obviously, if a patient has something that's clinically urgent and is very young, we really like to see them in the office. Patients with new onset seizures, or a type of seizure called infantile spasm, is probably going to require a hospitalization. And any set of symptoms where hospitalization is likely, you might as well just come in and let us see you so that we can, make the hospitalization go faster. I take care of people with neurologic diseases is the mitochondrial component. New onset symptoms of progressive neurologic illness, such as weakness, imbalance, sensory changes. Again, these are serious problems that probably warrant face-to-face visit. And when I first wrote this slide 2 months ago, as I was preparing this, I put new patients. That you really should see new patients face-to-face. And I got to tell you that really in the matter of a few weeks, most physicians have gotten used to seeing new patients using telemedicine and then cherry picking who really needs to come in for portions of a physical exam If someone's coming in for blood work, we can do the examination at that time. But we're getting more comfortable in seeing new patients using telemedicine services, especially those with the audio-video link. Where telemedicine is definitely beneficial is when you have a patient with identified but stable medical problems. And I can tell you that the vast majority of my patients I've seen in the last 2 months have stable and identified mitochondrial disease, and a couple have had unstable but identified mitochondrial disease. And in all situations, I've been able to get the job done using telemedicine. A lot of times we do medication changes or therapy changes, but we've been able to get the job done using telemedicine. It's been helpful because I know these patients, I know what they look like, and I know the families, so it made it easier. Any illness that requires frequent medication management when a full physical examination is not needed is a great opportunity for telemedicine. I'm currently seeing 2 patients on at least a weekly basis because they need fine tuning. These are 2 patients that would not be able to come in to see me every week because one lives very far away and the other is neurologically quite impaired, and just getting her to the hospital would be difficult. Discussion of test results like genetic results now can happen face-to-face via a video connection. And you can have a very personal conversation with patients for things like test results or management decisions. Patients with simple questions may be best served by telephone evaluation or digital evaluation. The digital evaluation also allows the patient to ask a question to the physician, and the physician responds in kind with a typed answer. And again, some new patient evaluations are working out quite nicely with telemedicine services. When you think about a new patient with mitochondrial disease, where the patient's already been seen by the local neurologist and the local cardiologist and the local gastroenterologist, and really what they need is a mitochondrial expert opinion, the physical examination isn't absolutely necessary because it's already been done by qualified healthcare professionals. Now, when you definitely need the face-to-face is when I need to lay hands on the liver, I need to listen to the heart, I need to look in the back of the eye. That can't be done with current technology using telemedicine. A lot, again, some of this information on this slide is repetitive in what I've said before. One challenge that we had is that we really thought that patients and doctors weren't going to accept telemedicine, that the concept of an office visit was a societal norm. And we're finding that in a 2-month period, we're adapting pretty well to this. And again, some parts of the physical exam just cannot be replicated using telemedicine. So what happens when the HHS 1135 waiver ends? State licensing rules need to be redefined. My hospital's already working with the state of Pennsylvania, trying to figure out how we're going to take care of patients in Pennsylvania. We share a property border with Pennsylvania. We're very near Pennsylvania. We take care of a lot of patients in Pennsylvania. Probably about 10% of our patients live in that state. So we want to be able to continue our telemedicine service after that. But some states are probably going to require partial medical licenses or full medical licenses. And if a physician wants to continue seeing their patient in New York or Colorado or Florida, they may have to get either a state license or a special permission to do so. When you think about there being 500,000 physicians having to contact 20 states each, that seems to be an overwhelming concept. The next question is, will the insurance companies continue to reimburse for the practice expense? Right now, our medical model is based on getting both the physician's fee and the practice expense fee paid for. And what happens if 40% of that disappears? And the final thing that happens when patients come to the medical center is they get testing at that medical center. That testing could be blood testing, it could be urine testing, it could be an MRI of the brain, it could be an orthopedic surgery evaluation. And what happens to those patients who are seen virtually and the hospital not able to capture what's called downstream revenue? Some other hospitals are going to capture that downstream revenue. And a lot of hospital payment models really require capturing that downstream revenue. So there's going to be a whole lot of changes taking place at big medical centers when the 1135 waiver ends. So as I said before, I really think telemedicine is here to stay. I think it's appropriate for many patients with mitochondrial disease, and happy to answer all questions as they come forward. Thank you for your attention.